Hey everybody, welcome to the ATS Resident Bootcamp Summer Workshop Series. We're going to give people another couple of minutes to log on, but make yourselves at home. And please go ahead and use the chat box function to tell us where you're from. Let all of these people trickle in. We have another San Diegan on the line. Yay!
San Diegoan. San Diegoan. San Diegan?
San Diegan.
Okay.
Oregonian?
Sure.
All right, we'll give people one more minute. Welcome, welcome. All right, so it is officially 4:02 on the East Coast. Wanted to welcome everybody to the final session of the American Thoracic Society Resident Bootcamp, which we converted to virtual bootcamp summer workshop series. So today we're going to start off with respiratory failure, led by Drs. Matt Drake and Anna Brady, both from Oregon Health Sciences University. Very happy to have you here today. And then after an hour, we're going to convert to closing remarks and a Q&A session. So feel free to share any of thoughts, concerns, questions. There's a lot of program directors on this call, and those of us who just have a lot of experience with running fellowships. So we're happy to have you here with us today. If you want to see the other workshops, this is the VBC wiki site. So you can go to this site, and soon all of the workshops that have been run to date should be up there. Recordings of both the large group sessions and the small group sessions with materials that you can use at home as well. For example, we have ventilation management, ECMO, PFTs, ICU emergencies. We also wanted to let you know that there is this ATS COVID Critical Care Training Forum that we host every Tuesday. So tomorrow at 8 p.m. Eastern Time, we're going to be talking about hypercoagulability in COVID. We've run 11 episodes. Those are all posted for free on the ATS website. So please make use of those. Lots of COVID tips and tricks and just how to manage people with severe ARDS. This wouldn't have been possible at all without our awesome chairs, Dr. Nirav Shah and Matt Drake, and then the entire working group really worked hard to put on this summer workshop series for all of you. We are interested in knowing what content you're interested in receiving moving forward. So please do fill out this survey. I posted it in the chat box too, or you can use your iPhone or Android to image that QR code. And what we'd like to know is, do you want webinars, podcasts, links to materials, and do you want it every week, every month, or just a website? So please let us know how we can help you in fellowship by giving you the content that you need educationally. So that brings us to today's session on respiratory failure, as well as our closing remarks. We would love you to turn on your video, answer and ask questions out loud and via the chat box. We're excited to have you here with us. We're going to send you into the breakouts after Anna and Matt do their larger group intros, and then we'll bring you back into the large group after those breakouts. Today we have 5 facilitators, so these are going to be your instructors, and you'll be entering one of those groups for the breakouts. And with that, I'll stop sharing my screen so Anna and Matt can take it away.
Sounds good. Thanks, Laura. Let me get some slides going here. So we've got a few introductory slides Dr. Brady and I are going to run through, and then we'll get you to the breakouts. And the whole point of today is to make this a really interactive kind of case-based format. These first 15 slides or so are just an overview, and then we'll kind of dive into some of the more details when you get to your cases. So first and foremost, let's talk about one of the things you're going to get very good at responding to in fellowship. And that's when you get the call about a patient. They can be young, they can be old, but you're going to get the very short of breath call from nursing, from the rapid response, and you've got to go assess these patients. So what's the first thing you need to know? And that really centers around the fact is, how sick is the patient? That's one of the immediate triage decisions you're going to need to make. And really, it comes down to whether they have signs of impending respiratory failure. I shouldn't say failure, impending respiratory arrest. And what I'm really looking for when I go to the bedside of a patient is, first and foremost, do they have markedly abnormal vital signs? Do they have increased work of breathing? In particular, things like inability to speak or speaking in short sentences, and then especially accessory muscle use. So if they're doing a lot of belly breathing, or if they're breathing, using a lot of their sternocleidomastoids to take breaths, intercostals, etc., it tells you this is somebody who's expending a lot of energy to maintain their current ventilation and oxygenation. And that's somebody I'm very, very worried about. You'll get very good at during fellowship of really recognizing some of the more subtle signs of somebody who's working hard to breathe and may not be able to keep that up for very long. Once you see things like cyanosis or decreased level of consciousness, you're really behind the 8 ball, and they really are nearly about to suffer a complete arrest, and so you need to move quickly. Now, Dr. Lux in one of the earlier sessions talked about this concept of there are certain situations where you need to move quickly and other ones where you can take a pause, start some therapies, and really think about what's going on. And this is really the cornerstone of your assessment of respiratory failure in these patients. Do you need to move urgently to intubate this patient, or can you provide some form of respiratory support while working up the etiology? At the cornerstone of that workup, I'm sure you've ordered plenty of these in residency, but thinking about our ABG as one of the real necessities in understanding whether this is a ventilation problem, an oxygenation problem, or a mix of the both. And then finally, of course, a chest x-ray. So why do I bring up the point about ventilation? So this graph is a little complicated, but stick with me. So on the x-axis, I'm showing you alveolar ventilation. So that's not even total ventilation, that's alveolar ventilation. And on the y-axis, you've got the partial pressure of CO2. And you can see if your dead space, your VD over VT, in a normal patient is about 1/3. That's your anatomic dead space. And you can see you need an alveolar ventilation of around 5 to 7 liters per minute to maintain a PCO2 of 40 with normal dead space. Now in diseases like ARDS, where the dead space fraction really begins to increase, to maintain that PCO2 of 40, you now need to increase your alveolar ventilation substantially. So if you go up to 0.5 or 0.67, 2/3, in more severe disease, you can see your alveolar ventilation is now in the mid to high teens. Now somebody may be able to maintain that for a little bit, but you can imagine then they get septic and they drop their serum bicarbonate, so now they need a PCO2 of 20, not 40. And very, very quickly, people run out of the ability to compensate to bring their PCO2 where they need to go. And thinking about the role that CO2 has, particularly in worker breathing, is really important when you start to think about the levels of respiratory support and the types of devices you're going to want to apply to somebody before they ultimately would need intubation. And so we've constructed this graph here to show you, we've got on one hand low flow devices, which are less than 15 liters per minute, intermediate flow devices that have slightly higher flows, and really thinking about these devices as oxygen support. And then finally, on the other end, we're thinking about things that are both oxygen support as well as carbon dioxide support. And those are your non-invasive ventilation, as well as high flow nasal cannula. And if you take one thing away today, I really want you to think about high flow as both an O2 and a CO2 device. And we're going to explain why that is. But really consider it as on the same playing field as non-invasive ventilation, and not just as a really souped up nasal cannula. So in terms of the low flow respiratory support, these are all limited by the amount of oxygen that can be delivered from the wall. So it's up to 15 liters per minute. And you've got both reservoir-based devices and non-reservoir-based devices. And so what do I mean by that? Well, actually, let me get to that in a second. First and foremost, let's start with this. This is a polling question. So this is your patient. She's on 3 liters of oxygen by nasal cannula. And I'd like you to tell me, based on the poll there, what is her estimated fraction of inspired oxygen? And Laura, is there, where is our polling option?
Sure, I can do that.
You see it?
There we go. It is now up.
Cool. All right. I'm going to share the results. Can you guys all see that? Laura, are you able to see that?
Yes. Yep.
Great.
I can see it, Matt.
So we've got a great spread here. You can see the winner from the poll is 30% FiO2. A number of you also thought it was 27%, and many also thought you cannot calculate. So I think this is an excellent outcome for the poll. This is exactly what I wanted to get at. But let's talk about why the actual answer is you can't calculate it without more information. And what do I mean by that? You probably are basing your calculations off a graph, a scale like this. With every liter of oxygen, you increase the FiO2 somewhere on the 3 to 4% range. Why is that not accurate? Well, the issue here is that when you're breathing at rest, you have a fairly defined inspiratory flow rate of somewhere between 25 and 40 liters per minute. When you take that breath in, you're bringing room air with 21% FiO2 into the oropharynx, and it's mixing with the oxygen you're getting from your device. If you're breathing at steady state and you're calm, that it may be a very predictable relationship between the FiO2, because you've got a predictable amount of oxygen, room air that you're breathing in and mixing with that FiO2, with the supplemental oxygen. However, in respiratory distress, you can imagine people are breathing with quite a bit more inspiratory flow, somewhere between 60 to 100 liters per minute or more. And when you do that, you're entraining a heck of a lot more room air. And because room air has 21% FiO2, you're actually going to decrease the overall FiO2 that's being delivered to the alveoli. And so I would remove the concept that there's a fixed relationship between supplemental oxygen and FiO2 being delivered. So to get around that issue, these reservoir-based devices were created. And so when somebody takes a very vigorous breath in, the goal is to be not entraining room air, but actually bringing air in from the reservoir, the bag in this case. So here we've got a partial rebreather and a non-rebreather. And the main difference between these two is the exhalation port. So you can see on the partial rebreather, you've just got an open hole on the side of the mask that allows a little bit of room air to be entrained when you breathe in, but also allows exhaled CO2 to escape. And the non-rebreather has a one-way valve. And so instead of allowing air back in, now you're only pulling extra flow from the reservoir bag. These, of course, allow you to inspire higher degrees of FiO2. Now I'm going to turn over the slides to Dr. Brady. She's going to take it from here and talk a little bit about intermediate flow devices as well as non-invasive.
Great, thanks, Matt. So depending on what you have available at your institution, you may or may not have this particular device, but the Venturi mask is pretty common. And the name really comes from the Venturi effect. And that has to do with the fact that as the tube, and so you can see, or Matt, you'll have to point out, because I don't have the mouse, that in the picture on the right there, you have all of those different colored hookups, and they all have, central tube. And so as the tube diameter decreases or narrows, flow through the tube increases. And so that leads to a drop in pressure. And so these can actually lead to a pretty predictable entrainment of room air, and coupled with oxygen from the wall, that leads to a predictable FiO2. And these might be color-coded, or at other places sometimes you can turn a dial that will change the diameter of the tube. But you can figure out more or less what the FiO2 is. Okay. And that brings us to the high flow nasal cannula. And so as Matt said, we really want to think of this as a totally different setup from the low flow devices. So many of you will have seen this before, but this uses a very high flow, up to 60 liters per minute, and a blender to really give you a more precise FiO2. It has a pretty minimal patient interface, and importantly, the air is heated and humidified. And so again, this is really high flow, 60 liters. So that's going to be able to overcome a lot of the room air entrainment that you get with low flow devices. If you're going to use high flow, it really needs to be just that, high flow. Okay. And so this is a chart showing work of breathing at different flow rates. So 12 liters per minute on the left, all the way up to 60 liters a minute. And you can see the work of breathing goes down as the flow is increased. And so we'll talk about this more, but the the main sticking point, one of the big take homes from today is that if you're going to use high flow nasal cannula, it's got to be high flow, at least 30 liters a minute, or you're not really getting the benefits. And we'll talk about in the cases more about why high flow is so helpful. The beauty, as Matt said, is that you can use high flow nasal cannula to address both ventilatory failure and hypoxemic respiratory failure. And you might use it slightly differently depending on what you're trying to address. So if ventilation is really the issue, you can crank up the flow and adjust your FiO2 to a target saturation. And I've had patients on FiO2 of 21%, but 40, 50 liters of flow. Or if it's primarily oxygenation, again, you're going to start with a relatively high flow. And then you can wean that, maintaining your high FiO2 as the patient improves. Great. And we'll talk just briefly about non-invasive ventilation, aka BiPAP. Remembering that BiPAP is basically like Kleenex is to tissue. So it's a brand name, but we tend to use it pretty broadly. So BiPAP is essentially a mechanical ventilator without a secure airway. So anytime you have a patient on BiPAP, we really need to be cognizant of that. And just like an invasive mechanical ventilator, it's going to give you a very similar readout on the screen, okay, with numerical measurements, scalars, and then the settings that you've dialed in at the bottom. Okay. And so these are the scalars that you're going to get. This is very similar to what you would get if you were looking at a ventilator set in any pressure control mode, kind of the pressure and then the flow and the tidal volume. As a pro tip, when I have a patient on BiPAP, I always use the respiratory rate from the actual BiPAP machine itself and not the recorded rate on the telemonitor. And if you're going to titrate non-invasive ventilation, you really now kind of going back to how you would do this for invasive mechanical ventilation. And of course, your determinants of ventilation are going to be your minute ventilation, your tidal volume, respiratory rate. Okay. Keeping in mind that you don't titrate a volume on non-invasive, that's really set by the patient's mechanics, driven by whatever pressures you set. So you'd have to adjust the pressures. And then for oxygenation, it's really your mean airway pressure. And so the pressure you're going to adjust for oxygenation is generally your EPAP, or the bottom number. If you go back a slide. Great. So if you look at the pressure scalar, you've got two lines there, your IPAP and EPAP, inspiratory, expiratory. So the EPAP, because we spend most of the time in the expiratory cycle, is going to be a bigger contributor to your mean airway pressure. And that's what we titrate for oxygenation. Whereas the IPAP is going to be the bigger determinant of flow and tidal volume. There really are not that many contraindications to high flow nasal cannula, other than inability to protect the airway and impaired consciousness, where you probably should intubate the patient anyway. Non-invasive, though, is going to have a number of contraindications, generally having to do with secretion management, right? So patients having a GI bleed, thick secretions, patients who aspirate, trauma, recent head or neck surgery are the big ones. And some patients just can't tolerate the mask. All right. So we are going to break up into cases. I see a couple of questions that came through. Okay. So one question about...
You see those, Anna?
Yes, you can pull them up.
Depending on the
so the PEEP, the question about PEEP we are going to dive into on the cases, so hold that thought, but that's a great question. And then a question about, depending on the manufacturer, that's interesting. Matt, I'm going to defer that question to you.
Yeah, so most of them are making 60 liters at the minimum in terms of flow rates. Some actually can go up to about 100 now. Liters per minute. I've seen some data, 60 liters better than 40s. So we'll talk a little bit more about the data in the cases. Better's a little bit tricky because there have been a number of studies that have really looked at the effects of increasing liters on physiology between 40 and 60. Like the graph we showed you, in some patients you will have a more significant reduction in work of breathing as you get to 60 liters versus 40. but most of the trials that were looking at outcomes like intubation and mortality weren't comparing 40 to 60 liters. They were comparing typically something like 50 liters to non-invasive ventilation. And so in general, I'd say that the goal would be to actually titrate somebody to the highest flow they can tolerate, because some patients actually will derive additional benefit when you go from 40 to 60 liters. But typically, often you'll find patients get a little bit intolerant of the flows when you get up above 50 liters. That being said, the main thing is you want to make sure you hit a minimum threshold, and I usually say that's around 40 liters, if you want to achieve the work of breathing effect from the high flow device. I see people on 20 liters and 35%, and they'll call it high flow, and the reality is you're probably not getting much ventilatory support with that device at that setting. You're purely using it as an oxygenator. And so really think about it. If you want to prevent intubation by reducing work of breathing, target the highest flows that they'll tolerate. There's a question about VBGs. I think we're going to get to VBGs in the cases. So let's loop back on that. And if we don't have time, if it's not addressed in the cases, let's address it at the end of the session, if that's okay.
One other thing to note, we are going to come back together as a group at the end of this session. So after we'll be in our breakout rooms, then we'll come back together for a few minutes at the close.
All right, so I'm going to send you all to your breakout sessions now. If you have any difficulties, raise your hand or you can text me. You'll be in those breakouts for 37 minutes and then we will come back together. So have fun, everybody. Welcome back, everybody. We're just going to let the breakout rooms close and come all back together. So I'm going to give everybody a couple of minutes to rejoin us. Looks like we only have one group back with us so far. Let's see. Great. Welcome back, everybody. We're just going to give everyone a few more seconds to rejoin us. And while we're sitting here, I'll go ahead and reshare this survey that you can.
So one of the questions that was brought up right at the end of our session, that was asked at the beginning, and I wanted to make sure everybody got a chance. But I was curious on Laura and Narav, what are your and Anna, what are your takes on VBG versus ABG?
I mean, I like them both. I love it when we're able to get the two at the same time, so that I have that backup option of tracking if it's if I'm going to be needing to know the CO2 over time. So I love it for that.
Do you work with anybody who's adamant that VBG shouldn't be drawn?
Nope.
No, me either.
I used to be that way, Matt, I have to say. I used to be like ABG or die, but I've relaxed. I do, kind of like Laura says, I do like to get kind of one of both at the beginning. And I have been burned every now and then by a peripheral VBG that just doesn't reflect what's going on. And that sometimes that's, when the nurses are really, using a tourniquet and they're trying to get the blood out. And so if I'm really in doubt, I will still always get an ABG, but I mean, absolutely a central VBG, no problem. There's good data that those are equivalent to ABGs. Peripheral, sometimes I'll get.
I like to always ask the question about kind of the A, how much does it cost? B, has anyone ever gotten an ABG because they hurt? Like in fellowship, we used to do research and draw ABGs, and it doesn't feel good, right? So if you don't have an A line, especially getting an ABG, there's a cost associated with it, both pain and actual financial. So we do rely on VBGs as long as they've been correlated, and central for sure, as Anna said, is great.
From any of the other session leaders, were there any other points that you thought you wanted to bring back to the main group before we do some wrap-up stuff? Deafening silence.
Yep. I can hear crickets.
Great. Things must have gone really well. Okay. All questions answered. Super.
Yeah.
All right. Laura, I'll turn it over to you.
all questions got answered. I chose the students that got put with me, or fellows that got put with me, chose poorly. So we didn't get through the last one.
It's all right. I probably built too many. I talk quickly, and so I could have done about 4 more cases in that time, but yeah, sorry about that. That's my fault.
I'm actually going to turn it over to Dr. Shaw, but trainees, please leave your videos on. This is going to be the last bit of our summer series workshop. We want it to be very interactive. If you want, please post any questions that come to mind in the chat box, but I'm going to turn it over to Nirav, so take it away.
Great, thank you very much. Well, we are at the conclusion here of our virtual bootcamp summer workshop series. So I'm going to go ahead and share my screen here and make this a video. All right, so you all should be seeing my screen, my PowerPoint. So this is our wrap-up session. I'm going to lead this with Matt Drake and Laura Crotty-Alexander, both of you who you guys are all familiar with now. You've been coming to the different sessions here for the VBC summer workshops, so you're well familiar with the site. This site will remain a resource for you for content. As Laura mentioned earlier in the session, this would not be possible without the people that were part of our RBC-VBC working group. You've gone through a bunch of sessions, so ICU emergencies, ECMO, vent management, PFTs, ARDS best practices, and we kind of picked sessions that would lend itself well to having a little bit of a didactic and then going into a breakout room, and also things that on day one of fellowship you kind of need to know about, right? And so there's a lot of stuff right now that that I think is on the horizon that you're going to encounter in the next week or so, or when you start your clinical rotations, that all of these will play into that. We talked briefly about the Critical Care Training Forum, so tune into that. I think we have a couple more to wrap up into the first part of the summer here, and then we're going to take a little break, reanalyze some of the data, and then bring it back in August. So even when you're a fellow, a first-year fellow, if you have time on a Tuesday at 8 p.m. Eastern, definitely tune into that. So now's a time where we can kind of ask questions and we can talk about things. And so I'm going to stop sharing my screen for a second. And we're going to start out with just an open forum for questions about any of the content that you learned. I know today was, there were some questions about high flow nasal cannula and respiratory failure, but really any of the sessions. We have really a diverse group of faculty on the call today that can help answer questions. And then maybe we can transition from there into some specific questions about starting fellowship. So any questions about any of the content that everyone went through and learned? Anyone have any burning questions that they want to get an answer to before they start fellowship?
So unfortunately my schedule, this was the only time it permitted me to attend one of these. I saw in the most recent email that there's plans to get the other sessions that were recorded up soon. Is there any time frame for when we're thinking that so I can watch those?
Yeah, I'm gonna let Laura take that one.
Yeah, so the ATS staffers have been working hard to review all of our video recordings and buff them up. We actually were able to record at least 1 and sometimes even 2 breakout sessions from each of the workshops too, so that you'll have those options. So I think we're aiming for the next week. Lauren, is that correct?
Yeah, that's correct. We're hopefully by the end of this week, beginning of next, we'll have everything up. So thanks for your patience, but we're working on it now. I'll email everybody once it's up.
Awesome. And you know, Derek, you asked that question, right?
Yeah.
I think that in addition to the content from this VBC summer workshop series, there's also on the site, on the wiki site, there's some of the pre-readings and the videos that we thought were kind of things that primed you for these sessions. So definitely look for those. And then Laura Crotty-Alexander has been really instrumental in spearheading when we did have an in-person live resident boot camp, there was also a virtual boot camp component to that. And so there's a survey with some questions that you guys are going to be answering that's going to help drive the content that we send to you on a semi-regular basis to get you through this first year. And if there's stuff, by filling out that survey, you guys give us feedback to tell us what we should include in that. And so we're all ears for what you need and to try and cater what we're doing. Laura?
Yeah, so for instance, like last year, we ran a sort of longitudinal boot camp. So every month we sent out an email that had links to podcasts, video series, little articles that we thought would be relevant to fellows for that month. So like August, maybe we were sending out, how to teach central line placement and stuff like that. But this survey that we posted in the box, we really want to know from you guys, because you're a different set of learners than we've ever worked with before. And so we want to know, do you want to get emails from us that has that kind of content? Do you want like workshops like this, like monthly? Do you want podcasts? So this is your opportunity to tell us what to do for you guys for the coming year.
I like it. That's said yes to all.
Yeah,
I love it.
The only other plug I would make is for the ATS reading list. It's a pretty large compendium of kind of the really core studies and manuscripts that define what drives our processes, our thinking, our clinical care. So if you go to thoracic.org and search for the reading list, there's both an adult and a pediatric reading list. Obviously, you guys are going into adult medicine. And then it's broken down by subheadings. There's a synopsis under each of the studies, so that if you want to bring, there it is, if you want to bring, an article to talk to the residents now that you're going to be overseeing a lot of their work, or if you want to bring something to rounds, this is a really quick and easy way to get access to like the really key topics that guide care. Thanks, Laura.
Yeah, so Matt is our resident expert on the reading list, because he organizes kind of the review of the reading list.
All right, full disclosure. I have a vested interest, but it's also great.
Yeah, it's fantastic. It's an awesome resource. Really, really important. And then even on the ATS site, I think Lauren Lynch from ATS posted in the chat box a link to the webinars and things like that we have that are there. Bavels, the Best of the ATS Video Lecture Series, is a phenomenal place. If you all haven't watched it, let me see a show of hands. How many people are palm critical care? And how many people are straight critical care? So you all, either way, are going to be doing bronchoscopy. So Rosemary Adamson from University of Washington has put in videos about bronchoscopy, kind of the beginning parts of what you need to know. So watch those videos. There are other videos that are in there as well. Definitely important stuff to look at. So any questions about any of that? Good. Thanks, Derek. That was a, yep, here's the Bavels, and you can see here, clicking on bronchoscopy, the intro, looking at how the anatomy, and they're really, even if you kind of just watch them to listen to Rosemary's voice, it's awesome. She has a phenomenal accent that keeps you entertained and really excited to learn about bronchoscopy in this. I will say that the endobronchial blocker placement video, I may have had something to do with that, so I'm biased there. But EBIS, transbronchial biopsies, all the things that you guys are going to get exposed to, you all are going to get exposed to, definitely look here. And then even other things that are in this, right? So PFTs or obstructive lung disease and things like that. So definitely a really nice resource of things to look there.
There's a really good e-vaping associated lung injury one that recently got put up there. Got, I think, like third place. Was pretty good.
Yeah.
I had nothing to do with that.
Nope.
Excellent. So let's get a show of hands here of how many folks have taken care of COVID-19 patients. So about half. Matt, I'm glad you raised your hand there in the middle. About half, maybe a little bit more. So I think that it's a unique time to be entering into fellowship in pulm critical care medicine. This is our stuff, right? I mean, we didn't ask for this to happen, but this is what we do on a regular basis. And so I wanted to kind of have a conversation or discussion around starting fellowship in the era of COVID. So are there things that you guys are nervous about, or are there things that you're excited about? Open forum here to have a conversation. Questions that you would want to ask somebody. I mean, you have frontline providers that have been taking care of COVID patients in the ICU on the call as well. Are there things that make you nervous?
So I don't know how many other people are in the same situation I'm in, but I'm going to be the first fellow as well as a friend that's going on as a co-fellow at my particular institution. It's a brand new program that we've established. And so it's kind of terrifying not having a senior fellow to reach out to, someone that's been recently through it. Not that I don't obviously trust the attendings and everything, but having someone that's been there very recently, having done it, is something that I'm concerned about, and not being able to. I have friends that are fellows in pulmonary critical care that I can reach out to, but not having someone within the same institution. A little nervous about that, transitioning from resident to being home crit fellow and being like a source. sorry.
Yeah.
But yeah, so.
So that's a good point. Does anybody have advice for Derek about that, about having fellows that are not necessarily at the same institution, trying to do starting off kind of brand new? I'll start with my advice, and that's it. If you go to the people that are on this call, or the leadership for the resident boot camps in the VBC, we're always available. So if you have questions that come up, definitely email any one of us. And also, if need be, you said you have friends that are in pulm critical care, but we can even pair you up with one of our senior fellows that you can kind of ask your questions to, and kind of, but I hear what you're saying, because a lot of it is institution specific. And so what I would recommend is, if you have junior faculty, they tend to be closer to the process than some of the senior faculty. And I would say, the way that we consider our fellows is that they're our colleagues, and we want them to feel as comfortable as possible. And so I would find a junior faculty member to kind of team up with a little bit and say, hey, I'm a little nervous about this, and this. Can I use you as a sounding board when this happens? And I bet you that they remember when they were their first year of training, and would be happy to do that. Anna, do you have thoughts about this?
I'll say something similar. I think, it's great to have, connections through ATS and other, professional groups that can be really helpful. And I totally agree. I think our fellows are really our junior colleagues, and people are there to help you. They're invested in your success. So they're going to be really excited to have you. So don't be afraid to ask.
Yeah. And Derek, go ahead, Matt.
It brings up this thing that it took me a while to realize, but creating networks, professional networks, is something that is so important to building your career. And you're going to have an opportunity. You're kind of being maybe forced into creating those networks earlier than others necessarily. But seeking networks, either, I don't know what city are you going to be in?
Warren, Michigan.
Okay.
So just north of Detroit.
So by finding programs that are in, geographic proximity and beyond, it's creating professional networks is really important, and you're going to have a head start from a lot of people. So do value that.
Okay.
I would also say, to add to that, kind of piggybacking on the networking statement, is that next year at ATS, when we're in San Diego under Laura Crotty-Alexander's hospitality, when you see one of us walking around, stop us and say, hey, I was in your virtual bootcamp summer workshop series. What's going on? Say hello. And then I'll introduce you to the next person, and then the next person. And that's how this happens, right? But those meetings are, if you can come as a first year to the ATS, I'll tell you that that's where I got hooked on being in academic medicine. That going to those national meetings and seeing people and seeing like someone give a talk on, steroids and in whatever, because we revisit it every year in some new fashion. And I was like, whoa, that's the person who wrote the article, right? Like they're the ones giving the talk. And so definitely that excitement and that networking is huge. So when you come next year, don't be shy to just be like, hey, I was in that BBC. And then that's how these things happen.
Okay.
I would like to add something as well. So I was in Michigan for my sleep medicine fellowship. Then I was applying for PUMCRED. So I wanted to get involved with, PUMCRED faculty in Michigan. And I had a chance to take part in Michigan Thoracic Society. They had their meetings. Actually, I think they do 3 to 6 months or something. There are some kind of seminars or something. And because you're living in Warren, it might be at a driving distance for you kind of thing. So might be you have to drive like 1 or 2 hours and you can get there. So maybe getting in touch with them might be of help for you. So
Cool. Thank you.
yeah, no worries.
There was a question on the chat board about, curious about general adoption of N95 versus regular face masks since the Lancet paper. Thoughts?
What do you think, Bart? What do you think about N95s versus regular face masks?
You're asking the government?
Yeah.
Okay.
I think I'm the only male physician that has grown a beard during COVID, but I just did an EBUS procedure this morning, and I got to use my Nike designed face mask for the PAPR. So my thoughts are that, I view this as just because we didn't know about COVID doesn't mean that it doesn't spread, just like every other respiratory virus. And unless you're doing aerosolizing procedures like bronchoscopy, a regular face mask is likely just fine.
Has anyone else's institution adopted strictly N95s?
No, I'll say that kind of in the academic center and in hospital settings, I feel like the majority of them are regular face masks, surgical face masks. Our policy at Maryland is that you have to wear a face covering to come into the hospital. That can just be a cotton face mask, but if you're in any patient care setting, it has to be eyewear and a surgical face mask. And then any procedure or anything that results in respiratory droplets. So if someone's on high flow or non-invasive, then you have to have an N95 or a PAPR or an elastomeric reusable respirator. But otherwise, it's a surgical face mask with eye shield.
And from a fellow standpoint, certainly know what your institutional policies are. And if you don't feel like you're an expert at putting on PPE or what PPE to use in certain situations, definitely ask. Definitely take the time to put on the PPE right when there's even when it's an urgent situation in a room, get it right, keep yourself safe, and feel empowered to speak up if you feel like PPE isn't right, there's uncertainty about the situation, or if your institutional policies don't seem in line with what's going to be the safest option. Definitely do that. It's really important to keep yourself safe, and just because you're a first-year fellow, oftentimes those are the people on the front line who are noticing the gaps in things that the senior people who come with policies didn't even realize. So definitely speak up, definitely learn how to put on PPE, and keep yourself safe. For sure.
I'm just looping back to the networking thing. Lauren and I were chatting on the side, and we had, before COVID hit, we were planning on setting up a Facebook page for this class of resident boot campers as your own like peer networking site. So if you guys would be interested, like would you actually join that group? So it would be anybody entering pulmonary critical care. So why don't you post in the chat if you would join that, or raise your hand, just so we would know, because we can set it up and put you all in it if you would like.
Great. See some hand raising and people saying, yeah. You know, I wanted to broaden the conversation just a little bit, and that's that we are in a unique time because COVID is something that we, none of us on this call have experienced before until now. But in addition to COVID being a big kind of a big thing in what we're doing, so is the entire movement of anti-racism, diversity, equity, and inclusion. And there's, you know, just talking to my own fellows at Maryland and kind of being in the region here, it's been a big conversation for us about, you know, how do we handle this and how do we support people that are kind of being marginalized, or how do we speak up? How do we use our voice as leaders to right wrongs and to make change happen? And so I think we're entering you all are entering fellowship at a time when there are two big things happening in our society right now, with COVID being on the medical side, but also this the issue with Black Lives Matter and kind of how we as leaders in our institution can enact change. So wanted to kind of open the forum up. I think that it is a time that a lot of us are nervous about things that are happening and how we can be people that enact change, and even how we handle it ourselves, right? How if a statement is targeted at me, how do I handle it? Things like that. So if there are questions that are kind of in your mind about that as well, please ask us. There are people on here that can definitely help lend some expertise to that. Don't everybody speak at once, okay? It's tough, I know. The Zoom, I would say that the third thing that's affecting us is that we're all doing this via Zoom, not in person next to each other, standing here talking, right? I think that's a challenge, but definitely type something in the chat box if you want. If there are things that you want to ask some of the faculty here, things you're nervous about, things that you're excited about, please let us know.
In your absence, I'm going to ask you a question, or I'll open it up to everyone. I remember being a fellow and kind of having the experience of a patient say something very derogatory to one of my residents, and I wasn't sure, kind of in this supervising position for the first time, like how should I respond? I don't know if you have any suggestions for that.
It's a good question, Anna. So I've had situations like that as well, where with a fellow, it's a specific instance that comes to mind where one of my patients really came down hard on one of my fellows, and this is a patient that I had been seeing for a while, and in a very kind of polite and respectful way, I said that, you know, this isn't going to be acceptable to talk to the fellow in this way. The fellow is my colleague and my partner, and that and it escalated. Obviously, I could be as nice as I wanted to be, but it wasn't going to go very well. It didn't go very well, but we ended up, you know, I had to in that moment really stand up for my trainee, because it's not acceptable for a trainee to be treated poorly by anyone, really. And I would say that I've had to do the same thing when I've seen a faculty member or an attending physician say something that I didn't think was okay as well, right? And that's even I think that's hard as well, because these are your colleagues at times, and you're standing there and someone says something. But I think that what I've learned is that it's gotten a little bit easier for me to say stuff as I've gotten a little bit older, and having looked back at it now, I wish I would have spoken up faster and sooner, and I wish I would have found my voice earlier in my career, and not just in the last kind of 5 years or 6 years, right? I can think back to times where I felt uncomfortable, and if I felt uncomfortable, that meant that the people around me felt uncomfortable too, and I should have said something at that time. But I do believe that it's never too late to say something, and that moving forward, I've committed to myself that being quiet is not something that I'm willing to do. And a lot of the friends that are on this call with me will laugh about me being quiet, because I'm definitely a talker. And so it's hard to be quiet in general, but it's tough to find your voice sometimes against people that are your leaders in your institution. that's exactly what we need to do, in my opinion.
That really resonated with me, Nirav, and I would actually encourage the trainees to, try to find your voice, because I really appreciate it when my fellows and residents and med students like bring something to my attention, because I feel like each year we have to kind of shift how we do things, how we listen. So I was trained in what I consider the Deep South. So I was at Duke for undergrad and med school. And so it was, normal for the guys the patients, the male patients, to basically sexually harass you all the time, calling you pumpkin and sweetie and so that was normal. So I was sort of trained to be like, yeah, you just ignore it, it's just what they do. And so, as an attending, I realized that I wasn't sort of shutting that down. I wasn't saying that was inappropriate just because I was so used to it, and I'm like, whatever, it's just, a 70-year-old sick person and he feels comfortable, and, that makes him feel a little bit better to say stuff like that. And it's always been helpful to me when my trainees are like, does that happen often? Does that not bother you? And I'm like, oh, this is a problem. It bothers them. So I need to do something different with my own behavior.
Yeah, Laura, somebody in the chat, Alex, says here from UNC still happens from time to time. I trained in I did my undergraduate in North Carolina, and the first day that we moved into the dorm, I was just telling Laura that my best friend from growing up and I went to UNC together, and I still remember the knock on the door. It was somebody that lived down the hall and came and said, we're going to pray for your soul since you're going to hell, since you don't believe in Jesus. And I was just like, oh my gosh, where am I? What is going on? This is insane, right? But you kind of, at the time, we just kind of just shut the door. But that's really the analogy that I use now, which is, I'm willing to shut the door on racism. I'm willing to shut the door on people that are being that are being inappropriate, and we need to make sure we speak up and support each other. And trainees. So I'm involved in the medical school side as well for things, and it's really a challenge to think about. If you step back and look at how people talk to people, I would encourage all of us on this call together to be advocates for change and leaders by example of how we should respectfully talk to everyone that we encounter.
You don't realize just how much influence and impact you have as a fellow, and how much the residents are looking up to you, how much nursing and other support staff. I mean, you are the central cog of your team, and the importance of speaking up in the moment and acknowledging that either verbal actions, physical actions, or anything like that is not appropriate, is not tolerated. Has a huge ripple effect across the institution, just like it does if you don't say anything and allow behaviors just to be, oh, it's just an old person saying something rude. And so you may not realize yet just how important your role is and how much impact you have, but you're a matter of hours away from stepping into that role. And it's a big deal, and continue to do good things.
I had a quick question.
Leader on the chat board said, what suggestions do you have for someone who's been in medicine practice for a few years and now going back to fellowship?
Yeah, I was mentioning that often those are the more mature fellows that we have, and I really enjoy working with them because they know how to write notes quickly, they're billing correctly. And they know how important the staff are and the interactions. So I think they actually usually, have a head start on some of the other fellows. But on the other hand, it can be hard to transition from being an attending to being a trainee where you're being told what to do. So I feel like that sort of mental framework shift is what I would focus on the most. I don't know if you guys have advice on how to do that.
So we've had a fair, you asked that question, we've had a fair number of people that have practiced something else before coming into our critical care fellowship. So home critical care has typically been a more traditional pathway where most people have either done a year of hospitalist or are coming straight from residency. But our critical care fellowship training program, a lot of folks have done another fellowship before coming in to that critical care training program, or have worked as an ER physician for a while and then decided that they wanted to do something. And I would say that the most important thing that they would probably tell you is that is similar to what Laura said, but that's that don't use it as a kind of a chip on your shoulder that, oh, I was an attending at one point, but use it as a kind of a jumping stone, if you will, to say, this is how I thought about it before. Let me think if I can think about it from a different perspective and try and look at things from different perspectives. And I think that applies for anything in general. When a lot of times you'll be in the ICU and maybe an ICU physician might say something like, we don't need cardiology or we don't need ID to do that. We got this or whatever. But my mind is always like, the more people you have that you can bounce ideas off of each other, the better. And so you're coming with experience as a internal medicine person. Use that experience to add to the dialogue, to add to the conversation, right? So these are things that you're going to know a little bit better than someone who's been practicing pure interstitial lung disease for the last 5 years. You might know the medicine side of things a little bit better. So use it where it's to your advantage, and then be humble and kind of be a sponge for the stuff that you want to add to that.
So going from an internal medicine resident to a pulmonary critical care fellow at the same institution, I hope that it won't happen, but I wonder if there's ever been an instance at one of your institutions where a resident from your institution transitioned to being a fellow and then was having difficulty with old attendees still treating them as a resident. As you guys said, you guys treat your fellows as like junior colleagues versus this person that previously saw you mostly as just a junior trainee. And I mean, I don't know how to phrase the question correctly, but if that ever comes up where someone's not treating you as a fellow instead of as like a resident, or, is there advice that you give someone in that type of instance or a situation like that?
Usually say, definitely bring it up with your fellowship director because they usually keep track of those things. And we usually discuss that like every 6 months when we're talking about our fellows, like how they're doing. That's part of it, because we tend to try and keep our residents because they're awesome and you know who they are and they're going to be great. So I think there's a lot of support for you, like people want you to succeed. But yes, I will see people who were my resident like 5 years ago, and when I see them now, I'm like, oh, it's my resident. So it can be tricky.
I would say most attendings and most people who you've been working with actually have viewed you much more like a colleague than a junior trainee. Particularly after you got over that intern year where you're kind of figuring out the system, like you're a high functioning senior resident and people view you much more like a colleague. And so I stayed at the same institution, and the overwhelming thing that I got was, everybody insisted that I called them by their first name suddenly, and everybody was, so I think it would be unusual for the most case to be treated as like a junior person at this point, particularly because you're the only fellow now. Like, I think they're going to look to you for a lot of expertise, maybe sometimes more than you imagined you'd have. So.
Okay, thank you.
I think you can use it to your advantage as well sometimes, just because if they treat you as a resident, you can ask stupid questions.
Right, Eugene had a question in the chat. Kind of what do you do if someone refuses care based on discrimination, kind of particularly if you're the only provider on, like for a night shift? That I would bump that one up fairly quickly. There are, depending on your hospital, there might be, so like we for instance at the hospital where Matt and I work, there's a policy that says that patients actually can't do that. And we also have an administrator on duty kind of 24/7. So someone you can contact. There could also be like the medical director of whatever ICU you're in. but there'd be a lot of people who would have your back and be able to support you in a situation like that.
I would just add in all of that, as fellows, you do not get paid well enough to deal with that.
Yes, that's why you should
Immediately bump it up to your attending.
That's what we're here for.
And it's unacceptable. And I would hope that all your institutions had very strict policies in place that patient discrimination towards providers is as unacceptable as any form of discrimination.
You asked a question about COVID-19 and affecting the number of bronchoscopies or the ability to do that. I'll speak for us, and each of these guys can do the same, but it hasn't been an issue for bronchoscopies for us. Our fellows are still participating in bronchoscopies. What it has become an issue for us is airway training. So we've definitely had, we've had an airway anesthesia rotation that's been part of our curriculum. And that's on hold for this, at least for the next few months. They're not training critical care trainees to do airways like that, the way that we had traditionally. So definitely, definitely there's some things that are affected by it, but I think that we're going to see a lot more of the normalization of things going back to the way that they were as the numbers come down. But again, so many things can change with the drop of a hat, right? If the numbers of COVID go back up and we go back into a surge situation, then again, things might change one way or the other. One thing I'll tell you is from a former fellowship director's point of view and from a trainee and someone who spent time at different institutions, it's adaptability and flexibility are your best friends, right? So the goal is to get you the best training you can get over the course of your training years, but that training never ends. The reality for me is that I learn as much from you all as you do from me on a regular basis, right? So just because you didn't get as many airways or as many bronchs or whatever as you would have, doesn't mean that you're going to be any less of a home critical care physician in my opinion. So things will ebb and flow for the next year and a half until we figure a lot of this out. But I would say that it shouldn't affect your numbers for bronchoscopies and things like that unless the overall institution numbers are down.
There's a bunch of postgraduate courses that are run with ATS International Conference that over the next couple of years, if you feel like there's parts of your practice that could use a little bolstering, those are a great way to spend some CME money and get some really focused training on stuff. So if bronchs or airways or any of that, keep an eye out for opportunities. There's many things after fellowship that I felt like I still needed to learn, and I still do. So those are great opportunities.
Yeah. The other thing I would say is that one thing I've certainly learned since becoming an attending is that I can still call people for help. So I absolutely do that, whether it's procedure or like, hey, can you give me a second opinion on this case? Just because you're done with training doesn't mean that you have to go it alone. There's always a community of people you can turn to.
That actually goes along with a side conversation I was having on a private chat with one of the trainees about whether it's okay to call your attending in the middle of the night. And so I was glad that they brought that up because often, we worry more about the fellows who don't call us because it's like, oh, they didn't realize that they didn't know this. Like how would they know this? They've been a fellow for weeks, a few months, like maybe even 8 months. It's like, we have years and years and years of experience taking care of these critically ill patients. So every time I get a new fellow, I make it very clear to them. I'm like, call me with anything. I would rather you ask and that we deliver the best care possible for this patient as opposed to you not wanting to wake me up in the middle of the night. I was like, this is my job. This is why I get paid tons and tons of money, right? Right?
Right.
You need to go to San Diego, it looks like.
I am, me too. Yeah, no, I would agree with that. I'd rather you call me than not call me. Better yet, call Matt. I'll give you his cell phone number.
Always available.
Yeah,
always.
For sure.
Yeah, so don't try and be the strong fellow who doesn't ask. And actually a lot of our residents who are rising fellows, they're like, what's the one piece of advice that you would give? And I would say, as a first year fellow, you're allowed to be dumb. You are brand new to pulmonary critical care medicine. Like in that first year, and especially that first 6 months, this is when you can ask any question and you're not considered dumb or unknowledgeable because you're a brand new trainee. And so it's a great time to just escalate your knowledge, and you can ask 50 questions a day, and you're going to gain so much more knowledge by asking those questions as opposed to trying to pretend you know the answer and not ask the question and say, oh, I'll look it up later, because you're not going to have time to look it up. So if you can ask the question, just keep asking questions so that you can learn as much as possible in those first 6 months. So you'll be a strong second-year fellow. And second-year fellows is a little bit harder to ask questions, even though you really still should. Anything you don't know, this is your opportunity to become the strongest physician that you can and deliver the best care you can.
I'll let you in on a secret. The attendings don't know everything either, despite how they talk with a lot of confidence. And so having a healthy respect for the fact that nobody knows everything and that this is going to be a really humbling career, even when you feel like you're on top of the game, that's invariably when I have a case come through that makes me have some serious reflection about things I might have missed on the way. So ask questions and just have a healthy respect for the complexity and uncertainty in the career you're entering. And it's one of my favorite things about it, but it also can be humbling at times. So.
Yeah, I would just say that this, comes all back to developing all of those contacts. I have people that I reach out to all the time to ask them questions. And so develop those contacts so you have your ILD person or your CF person or your PAH person, so that, because there is too much to know it all. But find your area that you want to focus on and then develop the contacts for everything else.
You should have your smart person contact list for everything in medicine, pretty much.
One of the things that I think it's a little bit different than this conversation, but one of the things that I think is unique about entering Pulm Critical Care Fellowship right now is that your patients that you're going to be taking care of in the ICUs, their families for the most part can't come and visit them. And so I would suggest to you to make sure you treat every patient as if they're your family, and take an extra few minutes. You're going to be tired. You're going to have been working many hours, but take a few extra minutes just to say hello to a patient, or to ask them about something that maybe isn't related to their medical care. Get to know them as people. I think that some of my most rewarding interactions over the last few months has been taking that extra 5 minutes before I've left the COVID biocontainment unit to just sit down and ask someone kind of, tell me about what you did, or tell me about what you're looking forward to when you get out of here, or whatever it is. If you can have a conversation with someone, or just sometimes just sitting there peacefully and playing a little bit of music or something like that with your patient. So make sure you don't forget the human side of this. I can tell by the questions that you all are asking that you all are picking the right field to go into. We're really excited about seeing you in this field and being colleagues with all of you, and working together in the future. The best stories are the fellows that ask to be fellow teachers in the boot camp because they did the boot camp as a resident and they realized how much it meant to them at that point, and how now they can come back full circle. And then really when those fellows become attendings and now they're running the boot camp, that's huge. So we all on this call are really looking forward to being colleagues with each and every one of you, and look forward to interacting in person in San Diego for sure, or if you're visiting the town that any of us are in. If one of our fellows is on the call, Hatun, I'll see you Wednesday. But
Also, Matt and Anna offered to buy all the drinks for everybody when we have a reunion session next year at ATS San Diego. I'll pick the bar.
Yes, that sounds good.
These are why our networks are so important. It's your willingness to hear me for things that I appreciate most.
Well, Matt, the last time, just for you, for all of you, just so you know what you're getting yourself into, the last time Matt bought me a beer, it was a yard. I believe that it was actually 1 yard tall.
We were in Dallas, and
Remember
they
that.
only sold them in 3 feet measurements. So you did a good job on it.
And you know what's amazing for those of you that are still on this call that to look at this is that the people that are on this call, like we're friends now because of ATS and because of being in pump critical care together and because of doing this stuff. But we didn't know each other 10 years ago. And so these networking things and these sessions and the collaboration across institutions and across the country have really led to some of my closest friends that I feel like, you know, this year with skipping ATS in person, I was like, I didn't get to see you guys. Like that was one of the biggest downers of not being there in person, other than the fact that we didn't get to do the RBC in person. So definitely take advantage of these opportunities.
And yeah, I don't know exactly what advice to give, but I do want to say, like, give yourself some attention and self-care, because, you know, fellowship is really hard, even without COVID. You know, without COVID, usually there was a lot of bonding across fellows, even, you know, new people joining. There's parties, there's way for people to get together and meet each other and form these bonds. And that's going to be harder this year. So again, I don't know what advice to give, but, you know, take care of yourselves, and, you know, we want you around for a long, long time. So we don't want you burning out or anything like that.
Absolutely. Very good. With that, I think that we appreciate you guys staying on for almost 2 hours of this session. We get as much out of it as you do. It's been a pleasure. And thank you for attending as many VBC sessions as you could. And please give us feedback, answer the survey so that we know what to do differently and how to make this better for you, and what kind of stuff to send to you through the VBC monthly newsletters and things. So congratulations to all of you.
Thank you for everything, everybody, for taking the time in these sessions.
Good luck with fellowship, everybody. Have fun.
Good luck, everyone. Congrats. Welcome.
Welcome.
Welcome.